Hello and welcome to this program. My name is Alpesh Amin, Professor-in-Chief of Hospital Medicine and Palliative Medicine at the University of California, Irvine, and Associate Dean for Clinical Transformation at UC Irvine Health. In this video, I'll review the National Institute of Health treatment guidelines for adults with COVID-19. Let's begin by reviewing a brief history of the NIH COVID-19 treatment guidelines. On April 21, 2020, the NIH guidelines were first developed by a panel of experts in response to the rapidly evolving COVID-19 pandemic. As the body of COVID-19 evidence grew, the guidelines were continuously updated. In fact, a total of 72 versions of the guidelines were released from 2020 to 2024. Now that the public health emergency has ended, the NIH decided to publish the final version on February 29, 2024. Despite this being the final version, it's important for healthcare providers to keep up to date on the latest COVID-19 data, especially since COVID-19 remains a threat to public health and new information about variants and therapies used to address COVID-19 continues to evolve. But remaining vigilant can be challenging since so many of us are ready to move on from COVID. And despite vaccines and other treatments, coupled with a less virulent virus, today's COVID-19 remains serious. I know that at my institution, COVID-19 has continued to impose significant clinical and economic burdens, especially during surge periods and among high-risk populations. And furthermore, COVID-19 has remained a significant cause of mortality nationwide. From January 2023 to August 2024, approximately 105,000 provisional deaths were attributed to COVID-19, which is equivalent to 7.5 times more than that of the flu. So while mortality due to COVID-19 has come down since the first 2 years of the pandemic, COVID-19 is the cause of substantially more deaths than the flu today. When I look at data like these, I am reminded of how important it is to remain vigilant and treat my patients with COVID-19 according to nationally recognized guidelines. So with that, let's take a closer look at the NIH COVID-19 treatment guidelines, focusing on the recommendations for adults hospitalized with COVID-19. The guidelines separate their recommendations into 5 groups based on disease severity as follows: patients who don't require oxygen supplementation, patients who require conventional oxygen, patients who require high-flow nasal cannula oxygen or non-invasive ventilation, patients who require mechanical ventilation or ECMO, and finally, patients hospitalized for reasons other than COVID-19, also referred to as symptomatic COVID, who are at high risk of progression to severe disease. Each category includes recommendations that have been assigned a rating based on available scientific evidence and expert opinions. Recommendations include 2 ratings: an uppercase letter indicating the strength of evidence, and a Roman numeral indicating the quality of evidence. Looking here, you can see that an A is considered a strong recommendation, while a C is considered weak. And you'll notice that the highest quality of evidence rating is supported by randomized control trials, subgroup analysis of those trials, and meta-analysis without major limitations, while the lowest quality of evidence is supported by expert opinion. Before we begin reviewing each category, let's look at the indication for VEKLURY. VEKLURY is indicated for the treatment of COVID-19 in adults and pediatric patients less than 18 years old, weighing at least 1.5 kilograms, who are hospitalized or not hospitalized, have mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death. VEKLURY is contraindicated in patients with a history of clinically significant hypersensitivity reactions to VEKLURY or any of its components. Now let's start with the NIH recommendations for adults hospitalized with COVID-19 who do not require oxygen supplementation. While it may seem counterintuitive to admit a patient without oxygen requirements, at my hospital, we consider it for those who are at high risk for progression to severe COVID-19. For example, an elderly patient who is immunocompromised and possibly frail, or who has multiple comorbidities such as diabetes, hypertension, or asthma. For this type of patient, VEKLURY is the only recommended treatment option. Early treatment with VEKLURY is key, as evidence suggests that the use of VEKLURY within 10 days of symptom onset may show the greatest benefit. However, it is FDA approved for use in adults hospitalized with COVID-19, regardless of time from symptom onset. Beyond that, the panel strongly recommends against the use of dexamethasone and other systemic corticosteroids for all patients in this category. Despite this recommendation against the use of corticosteroids in this population, there continues to be clinicians who use corticosteroids for this category of patients. You can see here that an analysis of ChargeMaster data found that 17% of patients admitted for COVID-19 who did not require supplemental oxygen received dexamethasone monotherapy. And beyond that, an even greater percentage of patients on low-flow oxygen received dexamethasone monotherapy. As you will see next, this practice runs counter to the NIH guidelines for the treatment of COVID-19. And here it is. For the low-flow supplemental oxygen inpatients, dexamethasone monotherapy is not recommended unless VEKLURY cannot be obtained. For most adults in this category, a combination of VEKLURY plus dexamethasone is recommended. Although VEKLURY monotherapy can be used for patients who require minimal conventional oxygen. Additionally, the guidelines recommend that patients with rapidly increasing oxygen needs and systemic inflammation who are already receiving dexamethasone add an immunomodulator to their treatment regimen. Inpatients with COVID-19 on low-flow supplemental oxygen are amongst the most common patient types we see at my institution. So understanding these recommendations is key to providing them with the best care possible. Before we move on to the next category, let's review additional important safety information. Hypersensitivity, including infusion-related and anaphylactic reactions, has been observed during and following administration of VEKLURY. Most reactions occurred within 1 hour. Monitor patients during infusion and observe for at least 1 hour after infusion is complete for signs and symptoms of hypersensitivity as clinically appropriate. Symptoms may include hypotension, hypertension, tachycardia, bradycardia, hypoxia, fever, dyspnea, wheezing, angioedema, rash, nausea, diaphoresis, and shivering. Slower infusion rates with a maximum infusion time of up to 120 minutes can potentially prevent these reactions. If a severe infusion-related hypersensitivity reaction occurs, immediately discontinue VEKLURY and initiate appropriate treatment. Transaminase elevation have been observed in healthy volunteers and in patients with COVID-19 who received VEKLURY. These elevations have also been reported as a clinical feature of COVID-19. Perform hepatic laboratory testing in all patients. Consider discontinuing VEKLURY if the ALT level increased to greater than 10 times the upper limit of normal. Discontinue VEKLURY if ALT elevation is accompanied by signs or symptoms of liver inflammation. Co-administration of VEKLURY with chloroquine phosphate or hydroxychloroquine sulfate is not recommended based on data from cell culture experiments demonstrating potential antagonism, which may lead to a decrease in the antiviral activity of VEKLURY. Now let's discuss patients who require high-flow nasal cannula, oxygen, or non-invasive ventilation. For patients in this category, a combination of dexamethasone and immunomodulator is recommended. The NIH guidelines recommend that VEKLURY can be added to one of these regimens in certain patients, such as those who are immunocompromised, have evidence of ongoing viral replication, or who are 10 days or less from symptom onset. Next, let's review the recommendations for patients requiring mechanical ventilation or ECMO. These patients should be promptly started on a combination of dexamethasone and a second immunomodulator. While there's insufficient evidence for the NIH guidelines to recommend either for or against the use of VEKLURY in this category, VEKLURY can be considered in certain patients, including those who have recently been placed on mechanical ventilation or ECMO, those who are immunocompromised, those who have evidence of ongoing viral replication, or those who are within 10 days of symptom onset. It is important to note that patients in this category who were already receiving VEKLURY should complete the full course of treatment. Now let's look at the final category, patients hospitalized for reasons other than COVID-19, without the need for supplemental oxygen, who are at high risk for progression to severe disease. Today, patients in this group are often referred to as having symptomatic COVID, since mandatory testing requirements at most institutions have stopped. An antiviral medication should be offered to all patients in this category. The panel's preferred recommendation is ritonavir-boosted nirmatrelvir, Although nirmatrelvir may not be clinically appropriate for patients with certain drug-drug interactions, and as noted in the guidelines, there are no data from randomized clinical trials that support the use of nirmatrelvir in patients hospitalized with COVID-19. If nirmatrelvir is inappropriate for use, then the panel's next preferred recommendation is VEKLURY. If neither of these medications are available, feasible to use, or clinically appropriate, molnupiravir can be used. Now that we've covered these guidelines, let's review some additional important safety information. For VEKLURY, the most common adverse reaction greater than or equal to 5% of all grades was nausea. The most common laboratory abnormalities greater than or equal to 5% of all grades were increases in ALT and AST. Administration should take place under conditions where management of severe hypersensitivity reactions such as anaphylaxis is possible. For patients who are hospitalized, VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19. For patients who are hospitalized and do not require invasive mechanical ventilation and/or ECMO, the recommended treatment duration is 5 days. If a patient does not demonstrate clinical improvement, treatment may be extended up to 5 additional days for a total treatment duration of up to 10 days. For patients who are hospitalized and require invasive mechanical ventilation and/or ECMO, the recommended total treatment duration is 10 days. For patients who are not hospitalized, diagnosed with mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death, the recommended total treatment duration is 3 days. VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19 and within 7 days of symptom onset for outpatient use. Perform hepatic laboratory testing and prothrombin time testing prior to initiating VEKLURY and during use as clinically appropriate. There is no dosage adjustment of VEKLURY recommended in patients with any degree of renal impairment, including patients on dialysis. VEKLURY may be administered without regard to the timing of dialysis. Available clinical trial data for VEKLURY in pregnant women have not identified a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes following second and third trimester exposure. There are insufficient data to evaluate the risk of VEKLURY exposure during the first trimester. Maternal and fetal risks are associated with untreated COVID-19 in pregnancy. VEKLURY can pass into breast milk. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for VEKLURY and any potential adverse effects on the breastfed child from VEKLURY or from an underlying maternal condition. Breastfeeding individuals with COVID-19 should follow practices according to clinical guidelines to avoid exposing the infant to COVID-19. Since the COVID-19 health crisis began, a significant amount of data have been generated to answer questions about safety and effectiveness of VEKLURY for multiple populations and across variant periods. A review of that full body of evidence is beyond the scope of this video. Instead, we will review only a subset of VEKLURY clinical trial and real-world data. First, we'll discuss the inpatient clinical trial that led to VEKLURY's FDA approval, Act 1. Act 1 was a randomized, double-blind, placebo-controlled trial in patients hospitalized with mild to moderate and severe COVID-19. Patients were randomized to receive either VEKLURY or placebo for up to 10 days, and the primary endpoint of this trial was the time to recovery within 29 days after randomization based on an 8-point ordinal scale. Secondary endpoints included clinical status on day 15 and incidence of mechanical ventilation or ECMO. In the Act 1 overall study population, patients treated with VEKLURY had a 5-day shorter recovery time compared with patients treated with placebo. In terms of safety, the frequency of adverse events was comparable between VEKLURY and placebo. Overall mortality was also evaluated in Act 1 as a secondary endpoint. At day 15, mortality was 6.7% in the VEKLURY group and 11.9% in the placebo group. At day 29, mortality was 11.4% in the VEKLURY group and 15.2% in the placebo group. However, the results did not meet statistical significance. Although it should be noted that Act 1 was not powered to evaluate differences in mortality in the overall population. In a post-hoc subgroup analysis, patients on low-flow oxygen treated with VEKLURY had a 70% reduction in mortality at day 29 compared with placebo. A statistically significant reduction in mortality was not seen in other subgroups. Now let's look at contemporary real-world study whose results complement some of the guidelines recommendations we reviewed earlier. If you'll recall, the NIH guidelines do not recommend dexamethasone monotherapy, yet as shown earlier, it is still being used in clinical practice. To further explore the relevance of this practice, a real-world study analyzed the effect of VEKLURY plus dexamethasone compared to dexamethasone monotherapy on mortality. Now, it's important to note that real-world studies should be interpreted based on the type and size of the source of data sets and the methodologies used in order to mitigate potential confounding or bias, and should be considered in the context of all available data. Results may vary between real-world studies. This study was a large retrospective comparative effectiveness analysis of all-cause inpatient mortality in adults with COVID-19 across the Omicron variant period. Data were obtained from the PINC AI healthcare database, which is a U.S. hospital service-level all-payer database covering approximately 25% of U.S. hospitalizations across 48 states. Within 2 days of hospitalization, all patients received at least 1 dose of dexamethasone, and those patients treated with VEKLURY received at least 1 dose of VEKLURY. The primary endpoint of this study was 14 and 28-day all-cause in-hospital mortality. Mortality was defined as a discharge status of expired or hospice. Approximately 33,000 VEKLURY plus dexamethasone patients were matched to 33,000 dexamethasone monotherapy patients using preferential same hospital matching. Key factors used in the matching process included age, gender, concomitant treatments, baseline supplemental oxygen, ethnicity, comorbidities, and hospital characteristics. Before matching, VEKLURY plus dexamethasone patients were younger, had lower rates of renal disease and diabetes, were less likely to have been on invasive mechanical ventilation or ECMO, and were more likely to have been on high-flow oxygen or non-invasive ventilation. After matching, characteristics were well balanced. The strengths of this study and analysis were that it included a large population of patients with COVID-19 from a multi-center administrative database, applied 2 well-established statistical methods to balance different groups due to confounding by indication, showed consistent results across those statistical methods, and complements and builds upon existing research for COVID-19. The limitations included the potential for residual confounding due to imbalances in unmeasured variables between treatment groups, even after propensity score matching. Also, the analysis did not account for certain information not in the database, including time of symptom onset, time since first positive COVID-19 test, vaccination data, and use of antivirals or any other treatment prior to hospitalization. Finally, to ensure that data used in the study were from hospitals that uniformly reported supplemental oxygen requirements, patients from hospitals that did not report any charges for low-flow oxygen were not included in the no supplemental oxygen charges group. As for the results, VEKLURY plus dexamethasone was associated with a 24% reduction in 28-day mortality risk compared with dexamethasone monotherapy. And as you can see on the forest plot, the line for each subgroup falls in the favors VEKLURY plus dexamethasone side and never crosses 1, indicating that VEKLURY plus dexamethasone was associated with reduced mortality risk across all oxygen requirements compared with dexamethasone monotherapy. At 14 days, VEKLURY plus dexamethasone was associated with a 26% reduction in mortality risk compared with dexamethasone monotherapy. The significant reduction in 14-day mortality risk was observed across all oxygen requirements in patients treated with VEKLURY plus dexamethasone compared to dexamethasone monotherapy. A propensity score match sensitivity analysis was also performed using a broader set of corticosteroids, including prednisone, prednisolone, methylprednisolone, hydrocortisone, and dexamethasone. The study found that VEKLURY plus a corticosteroid was associated with a 24% reduction in 28-day mortality risk compared with corticosteroid monotherapy. At 14 days, VEKLURY plus a corticosteroid was associated with a 25% reduction in mortality risk compared with corticosteroids alone. The reduction in mortality risk observed in the VEKLURY plus corticosteroid group was statistically significant across all oxygen requirements at both 14 and 28 days. So as you can see, the outcomes of this study further support the recommendations for the use of VEKLURY in adults hospitalized with COVID-19 within the NIH guidelines. And as a clinician, understanding how VEKLURY has performed in the real world, especially as clinical practices have evolved and the virus has changed, helps to inform how I treat my patients with COVID-19. As we conclude this program, let's take a moment to summarize the key takeaways. First, COVID-19 remains a major public health priority and has resulted in 7.5 times more provisional deaths than the flu. The NIH COVID-19 treatment guidelines include VEKLURY as a recommended treatment option for adults hospitalized with COVID-19 across disease severity categories. In clinical practice, patients hospitalized with COVID-19 continue to receive dexamethasone monotherapy, a practice that deviates from guideline recommendations and goes against available data. Finally, clinical trials and real-world evidence support VEKLURY as a standard of care for adults hospitalized with COVID-19. Thank you for taking the time to watch this video. I hope you found the information valuable. To learn more, please visit VEKLURYHCP.com.